children that can initiate treatment. Next slide. When it comes to West and Central Africa, we can see that only 37% of the children were diagnosed with HIV. Now, once again, we have a low case identification, and also only 37% of children living with HIV were on treatment. So we can see that in North Africa and also in Central Africa, we still have low case identification. Therefore, we still have low number of children that are enrolled in care and in treatment. And the viral load suppression is also very low, which is about 30%. Next, which is the East Southern Africa, where is the most progress that we have. East and Southern Africa, where is the progress that we can see, is the region that is most heavily impacted by HIV, but has made a significant progress in reducing numbers of new infections and AIDS-related death. And we can see that 64% of the children living with HIV were on treatment, but only we can see that in terms of viral load suppression, we're still low with 51%. Next. Based on that, what are the challenges? Why we still have those differences in terms of treatment cascade? First of all, we can see that we have to really categorize the things between what is the pair, mother and children. When it comes to the mother, we still see missed opportunity with prevention of new infections among women living to high MTCT, mother-to-child rates, low case identification. I could show through my previous slides that we still have low case identifications. We still have missed opportunity for timely diagnosis and linkage and continued on treatment for women in childbearing age. This is one of the challenges that we can see. In terms of service delivery models, we have a lot of service delivery models, but they are not adapted to child and caregiver needs at this moment. Next slide. We also can see that we have high stigma and discrimination. We still have limited investment in the implementation of interventions, weak health systems that supports integration based on efficiencies, limited community engagement and empower. At the same time, we have no availability of friendly pediatric formulations such as single-dose tablets at that moment, but now we can see that there's a movement to have a single dose. Linkage and retention to care in terms of impact on treatment cascade, mainly on viral load suppression, low quality of clinical service, and above all, the universal health coverage still not consolidated in our settings. Those are the challenges that we have. So how can we close all these gaps? Next slide. First of all, as we know and we saw in the presentation this morning, that we have several countries that we still behind. Based on that, we had to create the Global Alliance to End AIDS in Chile by 2030. So we identified 12 countries that need to speed up the impact on the response, and we are based in 4 pillars, which is accessible testing, optimized treatment, and comprehensive care for infants, children, and adolescents, closing the treatment gap, as we can see that we're still behind when compared to adults for pregnant and breastfeeding women, mainly when we look to the population of adolescent girls and women living with HIV, preventing and detecting new HIV infection among pregnant women and breastfeeding adolescent girls, and last, address rights, gender equality, and social structural barriers that hindered access to. So in terms of human rights, we also have something to tackle. So based on this Global Alliance to End AIDS, how do we close the gaps? Next slide. When it comes to the first 95, which is diagnosis, with the main problems are diagnosis and linkage to care, we have exposed children 0 to 18 months and children older than 18 months to 14 years old. We have to really tackle these main things in the first 95. We have the testing of every child with the signs and symptoms and suggestive HIV. We have to still do that. We have to do the expansion of point of care. We have to do routine testing for priority groups like children, adolescents, or women living with HIV, and also the OVCs. We have to do the routine testing for all hospitalized children. Implement community testing, tracing of index K, self-testing, integration of service like vaccination, triage, nutrition. I think it's important that HIV has to be integrated instead of being in a silo. Next slide. This is what we can do for the first 95. In terms of second and third 95, which is treatment and viral load suppression, It's important to implement pediatric and family-focused DSD, which is different models of standardized clinical care, improve the quality of care, including the management of complicated clinical case. Here I'm talking about advanced disease. It's important that we have to tackle also providers, which clinical mentorship, reduce the pill burden with the single tablets, continue innovation in treatment access. You also have to do the rapid transition to children on ART to DTG and improve treatment outcomes such suppression. When we see that in West and North Africa, the suppression is still low because we see that the transition to DTG has been a little bit slow. Next slide. Continuing in terms of second and third 95, it's important to have peer support intervention target all priority populations, which include prevention, support for adolescent girls, pregnant women, treatment support for children living with HIV, use initiatives, platforms, and community actors to support the connection and maintenance of children to treatment. We also have to engage and empower communities to participate in the design and monitoring of the quality of the programs, allowing the designing of the models that respond to the needs of population. We still have to do sensitization campaigns of testing and treatment literacy, because sometimes we don't know why it's important to test, why it's important to link to care, and why it's important to maintain in care. We also have to support from the mental mother and oversee programs and have continuous improvements on the service quality. So those are the ideas that we brought, how we can close the gaps in terms of the first, second, and third 95. And the last slide, which is thank you. This was my last slide.
If you could retake your seat, and then we're going to hand over to the next presenter, who is Prof. Musime. That's the one. Thank you. Over to you, sir.
Click again, yes. Yeah.
Thank you very much, Linda. My presentation is going to be focused on treatment, and we are going to look at antiretroviral therapy through the ages, and we'll consider optimal regimens for children and adolescents living with HIV. Next slide. So the regimens we are going to consider are dual regimens, which will be tablet regimens. Then we'll consider long-acting injectable ART, which will also be dual regimens, but long-acting. And then we'll look at options for second-line ART. Next slide. So by way of background, we know that children and adolescents face lifelong ART amidst treatment fatigue, as well as long-term toxicities. And the regimens that we need to be easy to swallow, have low risk of toxicity, but yet remain highly effective. And the options that are considered along these lines, one, a single tablet regimen, meaning these can be taken once a day, and so that they avoid having to remember multiple times. The second approach is having dual therapy. These are tablets that reduce toxicity potentially because you have fewer classes, and then also long-term injectables or long-acting injectables, because those reduce the need to have to swallow tablets every day. Next slide. So with the dual regimens, let's look at what happened previously. So the early studies that were done on NRTI-based regimens showed that the regimens that were considered at the time were inferior virologically when compared to either NNRTI-based regimens or PI-based regimens. Now, the more recent studies which have utilized integrase inhibitor-based regimens, that is DTG and 3TC in adults, have showed non-inferiority when compared to the triple ART regimens. The studies considered here are Gemini 1 and 2, as well as Tango. Then we also have the long-acting injectable regimens that have been tested, that is cabotegravir and rilpivirine, and these have shown non-inferiority when compared to triple or ART oral regimens. Next slide. So I'm going to look at two studies that have been done on dual regimens among children and adolescents. That's the oral tablets. One is on naive adolescents, and the others are ART experienced children and adolescents. So the one on naive is the DANCE study, and then the one on which has shown some preliminary results that were released at the IAS in July, and then the D3, which is ongoing, which is on ART experienced children and adolescents. Next slide. So DANCE considered the safety and efficacy of DTG and 3TC, and as I said earlier, it was in naive adolescents. Next slide. Next slide. So this is the design of DANCE. So it's when you look at the yellow box, this is the inclusion criteria. The ART naive adolescents between 12 and 18 years with a plasma viral load of between 1,000 and 500,000. The weight was over 40 kilograms. And then when you look at the flow of events, they were followed up for 144 weeks. The primary analysis at week 48. And the key outcome is virological response. Next slide. So this is the slide that is showing viral suppression at week 96. Now, what is shown here is the proportion of patients with a viral load of less than 50 copies per mil. And when you look at all the analysis, which was done by intention to treat, both the main analysis and sensitivity analysis, it showed that viral suppression was maintained at very high levels. Over 80% for the most part remained suppressed on DTG and 3TC, and these were naive, remember. Next slide. This is for the CD4. The CD4s rose over time, and they remained quite high in both the analysis, whether the main population or the sensitivity analysis. Next slide. The event rates were low. There was only one drug-related event, and which was a reduction in the glomerular filtration rate, which showed that the regimen was largely safe. Next slide. So what we can conclude from DANCE is that DTG and 3TC was well tolerated, demonstrated high efficacy, and had a high resistance barrier in ART naive adolescents. And these results, plus the adult data that I talked about earlier, support the use of DTG 3TC as a first-line ART option in adolescents. Next slide. I'll quickly talk about the ongoing D3. Next slide. The difference between the DANCE and D3 is that D3 is on an ART experienced population and has a wider age range, 2 years to 15 years. So these children are being enrolled as already on ART and suppressed. So they are randomized either to receive DTG 3TC or DTG and 2 NRTIs. They are followed up for 96 weeks, and the primary outcome is a viral load of virological failure over 50 copies per mil. There are some PK sub-studies embedded therein. So we look forward to seeing what will come out of this, whether viral suppression will be maintained. Next slide. Now I'll talk about the long-acting injectables. There are 3 studies that are presented here in adults. One is FLAIR, another one is Atlas 1 and Atlas 2. So FLAIR compared oral regimens compared to injectables given every 4 weeks. Atlas compared oral regimens and the injectable, cabotegravir, rilpivirine, given every 4 weeks. Then Atlas 2 compared cabotegravir and rilpivirine given every 4 weeks and then every 8 weeks. So in all these comparisons, there was no difference in viral suppression. That means the oral regimens did as well as the injectables, and the injectables given every 4 weeks did as well as the injectables given every 8 weeks. Next slide. So there are ongoing studies in sub-Saharan Africa. CARES and Impala are in adults. LATA and MOCHA are in adolescents. Next slide. I'll briefly talk about LATA. LATA is randomizing children, the adolescents, either to receive the injectable cabotegravir and rilpivirine every 4 weeks when compared to a DTG-based oral regimen, that is TAF FTC or TDF 3TC, with DTG daily compared to the cabotegravir and rilpivirine every 8 weeks. So that is being compared, and the primary outcome will be viral load at week 96. So we really look forward to seeing what will happen in this population as well. Next slide. So lastly, I'm going to talk about options for second line ART, and this is on CHAPAS 4 results. These results were also released at the IAS in July, and this was a factorial 4x2 open label trial. It enrolled 919 children that were randomized either to receive TAF FTC or abacavir plus 3TC or zidovudine 3TC. They were further randomized either to receive DTG or darunavir, ritonavir, or atazanavir, ritonavir, or lutpinavir, ritonavir, followed up for 144 weeks, but the primary outcome was at week 96. Next slide. So in the baseline characteristics, these children were recruited from 3 countries, Uganda, Zambia, and Zimbabwe. The Zimbabwean sites were UZCRC in Harare, and then there was Mpilo in Bulawayo. So there were no major differences between the 2 groups in baseline characteristics. Next slide. So in the NRTI backbone, that is comparing TDF 3TC and abacavir or 3TC, TAF FTC, sorry, not TDF, but TAF, please note the difference. TAF FTC was superior to abacavir or zidovudine 3TC in the viral suppression, and that difference was statistically significant. In the anchor drug comparison, DTG was shown to be superior to abacavir or atazanavir, ritonavir, and then darunavir, ritonavir showed a tendency towards superiority to lopinavir, ritonavir, and there was no difference between atazanavir, ritonavir, or lopinavir, ritonavir. Next slide. In terms of adverse events, in the ART backbone comparison, TAF, between TAF, FTC, and zidovudine 3TC, there was no difference in the adverse events. Next slide. In the anchor drug comparison, what was seen as a difference was a slight increase in hyperbilirubinemia that was associated with atazanavir, ritonavir. Next slide. So what we can conclude from CHAPAS 4 is that TAF FTC was superior to abacavir 3TC or zidovudine 3TC, while DTG was superior to atazanavir, ritonavir, and lopinavir, ritonavir virologically, and there was a safety profile of those 2 superior drugs. There was also a tendency towards darunavir, ritonavir being superior to atazanavir, ritonavir, and lopinavir, ritonavir, and the drugs TAF FTC, DTG, and darunavir, ritonavir had favorable safety profiles. So we hope that from this, if we had fixed dose combinations of TAF FTC plus DTG or darunavir, ritonavir, or atazanavir, ritonavir, that will increase the options for safe, effective second-line ART. Next slide. So in summary, in my presentation, we note that there have been great steps in trying to optimize ART for children. And the regimens that are being considered, that's the dual regimens, as well as long-acting injectables, they provide opportunities for prolonged care, meaning children and adolescents can remain on drugs for a long time that keep them safe from toxicities, but also remain suppressed. And then the CHAPAS 4 results provide opportunities for FDCs that of these various regimens that and it also supports their inclusion on the WHO priority list. Thank you very much.
Okay, so we'd like to take questions and make it a little bit more interactive. You've heard now from the two previous speakers. We're doing very well on time. Thank you so much. So, do we have any questions from the audience here? From the two presentations we've just heard now. It seems like it's the two presentations were crystal clear. That's why there are no questions, right? I can see someone. Do we have a roving mic there? At the back there? Please kindly introduce yourself and direct your question to any of the speakers, the previous speakers.
My name is Alex Maleti. I'm a biomedical scientist. My question would go to the second speaker. I'd like to just inquire, were there any results or inquiry done with regard to drug resistance on both the dual regimen and the long-acting drug that you just presented? Any insights on that? Thank you.
Just a minute. Do you have any other questions so that we can take them on the roll?
Yes.
The lady in the pink layer.
Thank you very much to the presenters. I had a question with respect perhaps to, traditionally we've always said antiretroviral treatment is 3 drugs. Maybe you can explain a bit regarding why 2. And then the other one, when you talk of the long-acting ones, they sound really brilliant, but how far are they, can we expect them in the next year, in 2 years' time? And if they do land, what is the price of them?
Excellent question. I had that question in mind too. Access versus cost in low middle income countries, and as well as dual therapy in terms of genetic barrier of BTG. So let's stop here. Probably those are very interesting questions for now. I think they're all directed to Professor Victor Musime. Over to you.
Yeah, now it's okay. You can hear me now. So let me start with the question on, I'll answer all the questions there are 4. One is, we have always known that ERT is 3 drugs. Why 2? The 3 drugs, yes, it has been traditionally used and we have used them successfully for a long time and studied the 3 drugs well. The 3 drugs are commonly from 2 classes, sometimes even from 3 classes. With every class that you add options, there are 2 things that you're dealing with. And these are children, you remember. We are dealing with toxicity. We are also dealing with development of resistance along the way. So whenever you have 3 classes, for example, you're exposing yourself to those 2 risks, toxicity and resistance, and also reducing options once you have cut through the resistance barrier. Now, the 2 drugs give an option, one of reducing the classes, and if you are able to reduce the classes, thereby reducing toxicity, that means you have several options along the way. Remember, you're dealing with a pediatric population that for now have to be on ART all their lives. So the 2-drug approach is to try and reduce toxicity while maintaining viral suppression. Then the second one about resistance tests, yes, for dance, for example, whenever there were any viral load over 50 copies per mil, they went ahead to try and check for resistance results, to do resistance testing, and no profiles were observed to my knowledge from that study. And then for the injectables, similar settings, there are ongoing trials that need to be done, but so far the resistance profile tests indicate that the 2 drugs, the integrase inhibitor-based regimens, have a very high resistance barrier, and resistance is not happening at a very high rate. There are few, but not to the level of causing worry. Now, the programmatic question. the long-acting injectables. How far are they in the rollout? At the moment, on the continent in sub-Saharan Africa, they are in trial settings, and hopefully once this comes up and they seem to be, the results indicate that probably they will be very effective because they are maintaining viral suppression. There's a very high acceptability from the acceptability studies done alongside. So that probably will increase the confidence, and hopefully they will be rolled out on a wider scale. At least they are being tested within our settings here. Regarding the price, I'm hoping that with demand, it's a very political question, but I'm hoping that with demand, they will be affordable. That is my hope. Yeah, so really, the greater the demand, in my view, the greater, the lower the price it will be. So I'm very hopeful about this.
Thanks so much. Hello. Yeah, no, thanks so much, Prof. Musime. I think it's clear, definitely for the economy of scale, in the early phase, that's going to be expensive. Don't expect it to be cheaper. Then secondly, the volumes will drive the cost. We know that supply demand cost is going to be cheaper when we get more volumes and requests from countries. But again, Dr. Prof. Musime, I think we need to discuss this, but off this session, because we only have 15 minutes left. We just returned from a drug resistance meeting in Cape Town, where we're seeing high level of resistance to DTG. And in that question from the back of the room is very important. If you have resistance to DG, I mean, you're dealing now with a monofunctional ARV, and this is more dangerous than probably toxicity. And then having resistance to DTG probably is the most, you don't want to see that in the next coming years. So I think we need to have that conversation later on. So we'd like to introduce the last speaker, and then we'll take it from there. Thank you.
So thank you to our first two speakers for sharing their insights and contributions on how to improve treatment in children. If we could load the video for Dr. Rachmanina, who has joined us from the US. She is online and will be able to participate in our questions. There she is. Good morning, Dr. Natala. Thank you for joining us. If we're ready to go on to the presentation now. Thank you.
Can you hear me? Can you hear me?
Yes, we can, loud and clear. Thank you for that.
Great.
Is it about to play?
Great. Are you going to play the video or should I move the slide?
There we go. I think we can press play.
If the sound is not good,
Yeah.
I can talk along the slide.
It's muted here. If you can unmute.
focus on helping children to thrive, looking in depth at the gaps in HIV care cascade for children and adolescents, and discussing the solutions. Well, let's start by celebrating the success. In over 1 decade since 2010, we were able to avert 3.4 million pediatric HIV infections. We have seen a significant decline in new HIV infections globally among children under the age of 15, with 58% decrease on new infection and 64% decrease in AIDS-related deaths. However, this progress is not enough. Currently, a child continues to die from AIDS-related causes every 6 minutes, and that means that by the end of our 45-minute session today, approximately 7 children will die globally from HIV-related causes. That success in decline of new pediatric cases is strongly driven by the increase in ART coverage of mothers during pregnancy and breastfeeding period. As you can see here in the green bars, we have seen quite sharp increase in ART coverage during pregnancy and breastfeeding, but over the last 5 years, while remaining above 80%, we see somewhat stagnated numbers. And that means that over 200,000 pregnant and breastfeeding women living with HIV are not accessing antiretroviral treatment during this vulnerable period for transmitting the virus to their children. You already heard a number of new pediatric cases from Dr. Kuto's presentation today, and already touched on the market regional differences where we have seen significant progress in the new pediatric HIV cases in Eastern and Southern Africa here in the red line, and much less progress in Western and Central Africa here in the blue line. Well, let's look more closely why and when children are being infected. Globally, almost half of all the cases are happening because mothers have not received treatment in pregnancy and breastfeeding. And for Western Central Africa, that's 2/3 of the cases. But if you look at the region which achieved some great success, such as Eastern and Southern Africa, you see approximately similar buckets of the colors between the women who have not received treatment, the cases of the new infection, and very concerning women who have been placed on ART at some point but have not continued treatment during pregnancy or breastfeeding period, highlighting the gaps where we need to address our efforts. When we look at early infant diagnostic cascade, we realize we also lag behind in our global AID coverage is less than 70%, and the regional differences are even more pronounced, with Eastern and Southern Africa AID coverage over 80%, under 25% in Western and Central Africa for comparison. And here I have tried to create 2 buckets of the gaps along AID cascade in the green color and highlight the solutions in a blue color. And you can see here that for missed AID opportunities, which we know are the major barrier, we have some solutions. We know we need to invest in laboratory infrastructure, strengthening an integrated person-centered approach to mother-infant pair tracking, such as cohort registers, joint provision of mother-infant health services and support services, and a community-based mother-mentor model. For the delayed delivery of the results and initiation of ART, we have very clear evidence of the point-of-care testing combined with the linkage to care and rapid initiation of ART in infants. And earlier this year at COI, we have seen evidence of the study from Mozambique and Tanzania that highlighted 73% decrease in infant mortality from AIDS-related causes in the first 6 months of life when these 2 approaches are integrated together. And Elizabeth Glazier Pediatric AIDS Foundation implementing point of care for AID testing between 2016 and 2019 highlighted marked differences between conventional AID outcomes and POCT AID outcomes. You can see here on this table the significant difference between median turnaround time between infant blood sampling and receiving results by the caregiver in the top row, initiation of pediatric ART on the bottom row, more than 5-fold increase in results received by caregiver by 30 days after sampling, and more than 2-fold increase in the number of children who have started an ART within 60 days after sample collection. Well, how about beyond AID? Let's look at the pediatric HIV cascade in the blue bars compared to adult cascade from testing to starting ART to being on ART and to viral suppression. You can clearly see red bars all exceed blue bars. For ART coverage, only 57% of children under the age of 15 are receiving ART, and among those adults with HIV, 77% are treatment. And if we focus with you on those children who are not on treatment, we realize that 62% of them are aged 5 to 14 years, highlighting that EID is not enough, and we need to focus our efforts on outpatient HIV testing of older children. And here the solutions are use of optimal screening tools, index case finding and testing, and the caregiver self-testing, other community testing models. Regarding the ART, we are now in DTG ART era, and we have done a great job scaling out pediatric DTG-based ART. But even in the era of more efficient ART, we are still seeing the children viral suppression rates of those on treatment being only around 81% compared to 93% of adults. Another significant contributor to AIDS-related mortality in pediatric population is advanced HIV disease, which is attributed to all children under the age of 5 living with HIV. And here the STOP model has been developed by WHO, Screen, Treat, Optimize, and Prevent AIDS, and I highlight the patient-centered DSD model developed by ACPAV. Very importantly here, along with screening, treating, and optimizing is the element of prevention, which is particularly applicable to pediatric populations where vaccinations are at its height throughout the life trajectory. And here, how are we doing? Well, actually not that great. 1 in 5 African children does not receive all necessary and basic vaccines, and we are losing over 500,000 of children in Africa each year who die from the vaccine-preventable disease. If we look at the combination of low rates of vaccination with other health threatening conditions, we see the malnutrition and stunting. On this map in the dark burgundy color, a percentage of stunned children at the age of 5 years of age, over 30% in African regions. And this is also hampered by very high rates of children being orphaned and vulnerable because of AIDS epidemic affecting not only their lives, but the lives of their caregivers and parents. In 2022, PEPFAR alone served 7 million orphans and vulnerable children and their caregivers. So what's the answer to these challenges? Is a continued health system strengthening. We need to continue to advance integrated wraparound service care models with health, nutritional, and other support services, all provided at one entry point, including OVC and key population programs. You cannot let the child grow and thrive without addressing early childhood development. And for that, we need much stronger tools and mechanism of supporting caregiver in health and child developmental literacy and supporting them through the community. Finally, I couldn't finish my presentation without addressing the adolescent HIV epidemic, where young adolescent girls and young women lead the new cases. We do know that while doing slightly better in terms of ART coverage, adolescents have suboptimal ART coverage compared to adults. They have lower rates of viral suppression compared to adults. And we know very well the barriers to accessing HIV testing and treatment by adolescents. Those include low health and especially sexual and reproductive health literacy, HIV and SRH-related stigma, including that one from healthcare systems, unsupportive school environments, and a very large burden of emotional behavioral challenges. And in recent years, focusing more and more on mental health challenges. Here on the slide, you see data from United States on very high rates of the mental health conditions, and we start getting more and more evidence on the burden of mental health disease in adolescents from African region in recent years. Multiple excellent tools have been developed by global stakeholders addressing the needs for adolescent care, and I highlighted few of those on the slide, but it is the same approach of using integrated models of care, combining HIV care with SRH, mental health, and other health needs. The youth services need to be user-friendly, need to include the peer support, and OVC and social protection, socioeconomical support. Special attention needs to be placed on adolescent girls and young women. And finally, because adolescents are at avant-garde of the digital development, we cannot develop the health services without integrating them with the social media and digital health technology. In conclusion, despite visible progress, we continue to witness significant gaps among the whole HIV cascade from testing to treatment to viral suppression between children and adolescents compared to adults. And we cannot achieve control of HIV epidemic if we do not prioritize and do not invest in these populations. Integration of HIV care with other health and nutritional services is needed at every stage, and it cannot be achieved without an efficient collaboration with the community. Thank you.
So, do we have questions from the last presentation? I think that was very straightforward presentation. We need to cooperate, communicate, collaborate with the community to get some of these programs being implemented. Any questions from the audience? Yeah, please. You can ask your question.
So maybe I can reflect to get the questions moving. From what I was struck by listening to all three presentations was that there are significant gaps throughout the cascade. And as health providers, we're not managing to deliver the program that we already have based on the knowledge and the tools and the medicines that we do have access to. So my question to all the speakers, maybe I can start with Dr. Couto, is to say, for example, in Mozambique, if you were to have a long-acting preparation that you were able to use to treat children, how do you think that might be different? How might that bypass some of the challenges that we're seeing in delivering the daily oral treatment that we currently have? How will having the injectable long-acting treatment for children bypass the gaps in testing and treatment, if not viral suppression? Any thoughts that you have? And then maybe Dr. Musimi can add his views as well. Thank you.
Thank you very much for that question. I think every introduction of new drugs is always a process of transition. And we recognize that every drug that's coming out is for the benefit of the children. In Mozambique will not be different. So, but we know that the process of transition sometimes can take time. And in terms of preparation, what we can do, in terms of what we have on stocks already, how we do move food and not have wastage. All these processes is that what comes. But if you have long injectables, we know what we all wish is that, first of all, the first outcome is to have viral load suppression. But at the same time, what we want to see is that there's very good adherence to this. Is that the main problem that we have at this moment is the adherence, and the children are dependent on the caregivers to do that. So when we have injectables, we have single dose tablets. I think is all the benefit that we see that we want to see is we want to see the improvement on adherence and consequently improvement on the viral load suppression. So for this process, I think is important to in this